Welcome back to the symposium for those who've joined us for the afternoon, and welcome to those just joining us for our last session. I'm Karen Ashley, Director of Education here at the Weitzman Institute, and I'm pleased to be here with you. And also, it's been my pleasure to work with our incredible team to plan this event, and I'm very excited for this final session. It's been a terrific day so far, and we thank those who have been here with us for it and for those who have just joined. I do have a couple of items of business to share, and then I'll introduce the moderator for our upcoming panel, where our panelists will discuss the role of inclusive health tech in healthcare innovation. As we shared in the previous sessions, Moses Weitzman Health System is accredited through joint accreditation for interprofessional continuing education, and through the Weitzman Institute offers CME and CE credits for many disciplines for today's sessions. To claim credits, look for the email that you will receive after this event. The financial disclosures for this session are listed on this slide. All relevant financial relationships have been reviewed by and mitigated through the Weitzman Institute's mitigation process. As a reminder for our live audience today, please use the Q&A at the bottom of your Zoom screen to submit questions to our speakers throughout the session, and use the chat function to share comments and questions with other attendees. Please note that all sessions today are being recorded, and we'll be sharing the recordings with you within the next week. And we have the following learning objectives for this session: discuss recent developments in digital technology, including AI and implications on safety net primary care practice; explore how the Supreme Court's reversal of race-based affirmative action has impacted inclusive representation in the health tech industry; and propose policy, research, and practice recommendations for improving inclusion of safety net primary populations, healthcare teams, and systems in ongoing advancements in healthcare tech. And now it's my pleasure to introduce our moderator for this panel discussion, Rashmi Rao. Rashmi is an accomplished entrepreneur and inventor with over 40 awarded patents on topics including artificial intelligence, health regulation, patient data privacy, and security. Rashmi is the managing director of R-Cubed Ventures, a business consulting company that offers strategic guidance to select startups within the industries of consumer, healthcare, and automotive technologies. Rashmi has a passion for innovation and is committed to making a positive difference in the world. And without further ado, I will now hand it off to Rashmi.
Thank you, Karen, and welcome everyone. What an amazing day we've had so far, and it's an honor to be closing this event, this great symposium, with this wonderful panel. Firstly, let me begin with introducing our exceptional panelists today. First off, we have Abner Mason. He's the Chief Strategy and Transformation Officer at Ground Health, a social impact company that manages complex connections between health plans, members, and community-based organizations to particularly fulfill social care needs for people everywhere. Welcome, Abner. Next, we have Dr. Irene Dankwa-Mullen, a physician leader, scientist, and industry executive with diverse local, regional, and national leadership experience in primary care, public health, health equity, and community. She is currently the Chief Health Officer at Mardi Health, a health equity startup company that promotes comprehensive case management coordination, targeting individuals and families from underserved and socially disadvantaged communities. Welcome, Irene. And last but not least, we have Shaheen Abdemolmin. She's the Senior Executive at Virtual Health, of the Virtual Health team at Tulsa Innovation Labs, an economic development organization pioneered by George Kaiser Family Foundation. At Tulsa Innovation Labs, Shahi oversees program development that advances virtual health research, startup, and workforce development initiatives. The goals of these initiatives is to catalyze the development, validation, and scale of virtual health solutions. Welcome, Shahi. What a supremely qualified and experienced crew we have here today. So let's dive right in. My first question is for you, Abner. According to a 2023 survey by the American Medical Association, around 30% of healthcare providers reported using AI in their clinical practice, with diagnostic AI tools being the most common. Telehealth and patient portals have become prominent forms of care delivery, before pandemic, but definitely post pandemic. And the CDC data indicates that approximately 37% of US health centers continue to provide telehealth services. But the question remains, are these technologies serving the underserved? Can you discuss any innovative digital tools that have significantly improved patient outcomes, especially for the underserved communities? Abner.
Sure. So thank you for the opportunity to be here. And maybe I'll start with talking about some of the challenges that we have faced and continue to face when we're trying to deploy new technology so that it serves underserved populations. A key barrier that I think we just need to make sure that we put on the table here is that the vast majority of underserved folks, low-income folks in the country, get their health care through Medicaid. And the Medicaid program is huge, but it has real challenges for technology companies when they're trying to deploy new technologies, innovative technologies, and I'm not only talking about artificial intelligence and machine learning. That's more front end, cutting edge. I mean, and I'll use telehealth as an example. Telehealth is not new. Being able to talk to a doctor either on the phone or use a computer is not new. But up until the pandemic, it was very hard for low-income folks who get their health care through Medicaid to actually use those kind of services. They weren't reimbursed. So you have a technology that wasn't new, but it was relatively, well, it certainly wasn't new. It was being used in the other lines of business like Medicare and commercial, but not in Medicaid because you couldn't get reimbursed for it. And so, I think that telehealth, the good news is the statistics you just shared, that it's being used now post-pandemic, and it's still being used even in FQHCs and other kinds of primary clinics that serve the underserved. But this is a cautionary tale about technology. It took a once in 100-year pandemic for us to provide a pretty basic service that other folks were getting to low-income people. So. And that gets replicated again and again when it comes to technology. And so we've got to make sure that going forward, we don't repeat the telehealth example. And we've got to figure out a way to make sure that we are deploying technology. You shouldn't have to wait 20 years to benefit from new technology just because you're poor or low income. And in fact, those are the folks that some of these technologies are best equipped to help, but we're not making it easy either for companies to get reimbursed for deploying these services in the Medicaid program. So I think, one, we've got to deal with that reimbursement issue in Medicaid. We got to accept that the vast majority of low-income people get their care through Medicaid. We've got to work with the NCOs, the managed care organizations, to make contracting easier for early stage technology companies that want to deploy technology into underserved populations. My company, we really struggle to work with health plans because it takes forever to contract with them. And when you're building new technology, and I'm sure the others will talk about this, the sales cycles are just really difficult, and they're even more complicated in Medicaid because it's different in every state. Unlike Medicare, for example, where one solution if you work with a plan, you can work across the country. In Medicaid, it's different in every state. So I won't get into the weeds here, but there are some real challenges that still need to be resolved. And there are some good examples. Telehealth is one of them. I think personalization, and I'll talk more about this, that AI and machine learning and other kinds of tools give us the ability to start to treat the patient or the member or the healthcare consumer like who they are matters, getting away from the one size fits all. So there are enormous opportunities, which I'll talk more about, but we're not going to see the true benefit of those if we don't deal with some of these policy issues that are just getting in the way. And I can talk about more of those, but I'll stop there and give others a chance to share their thoughts.
Yeah, Shahi, Irene, any thoughts on innovation and adoption happening the last in Medicaid, Medicare, the government? focused organizations, that's the only way that most of the masses, and especially the underserved communities, get their care from, right? And so it is so symptomatic of what we see. And it is also the cautionary tale. So any thoughts on this from either of you? Especially Dr. Irene, thoughts on, I know you've worked in the digital health space for a very long time.
Rashmi, I think we will slowly start to see a shift in, CMS, Medicare, and Medicaid being the last to them being the first in the few years, especially as we transition to, from transition to value-based care. But I think more and more startups are starting to think about these unique avenues and how to work with CMS to be able to find these pathways to success. I think one example that I could think of is sort of home modifications, and how I think in 48 states, CMS and Medicare and Medicaid will reimburse for home modifications, medical home modifications. And now we're starting to see more and more companies sort of focus on this like smart home and assisted living technologies that are able to integrate into the home. And I think our startup founders are becoming more savvy. And I think also the shift in value-based care, the synergy of the two is going to create a bit of a shift in that paradigm where we start seeing more technologies brought to the Medicare and Medicaid populations first, as we move into the future.
Absolutely. Yeah, I'm definitely seeing that. And that was a great example as well. Just to, I have a follow-up question for you, Irene. Mm-hmm. We've seen that, we know we have data which shows that adoption of some of these digital health technologies, whether they're digital health records or even AI-driven predictive analytics, it can actually reduce up to 10% readmission rates into some of our FCHQs and others. But there continues to be areas where these technologies are not addressing those specific challenges faced by safety net hospitals and health systems. Can you share what those limitations do you have for our audience here to learn a little bit more as we start thinking of what are those solutions that could be unique to our safety net providers and how do they start getting addressed? Because there is a tremendous value and we have data to show.
Yeah, no, absolutely. You're right that technology has significantly advanced primary care. It has informed nursing practice, public health practice, but there are really areas where it falls short in addressing those challenges faced by safety net providers. And there's several key areas, but I'll give a few. And one is, for example, the human touch and personalization. And Abner had touched on this, that technology can sometimes depersonalize care, making patients feel like they're being treated by machines rather than people, right? A lot of our digital health tools, such as the chatbots and automated phone systems, replace this human interaction with these machine-led communication that can make patients, especially from socially disadvantaged communities, feel further disconnected, feel further undervalued, and they miss the empathy. They miss the reassurance that the human interactions provide. And so that's definitely one, in addition to sort of technology that really is many technologies are designed with a broad user base in mind, right? So it leads to generalized solutions that may not necessarily meet the specific needs of individual patients. And if we want personalized care, it requires really comprehensive, accurate patient data. But sometimes the data collected from these tools, for these digital tools, may be incomplete or lack that context needed to tailor effective care. And of course, privacy concerns also limit the amount of data. So, that's one. Another one is actually, so in terms of personalized depersonalization, I think balancing the technology, because you asked for recommendation, with human interaction, ensuring that the care teams are trained to use the digital tools to, not replace personal connection, but incorporate some patient-centered communication and training, and continue to maintain face-to-face interaction. But one other huge issue is socioeconomic and environmental factors, right? And we know technology alone cannot address the broader social determinants such as housing and food insecurity. So even though it has the potential to revolutionize healthcare, it still has significant limitation in addressing these. And one thing, even for environmental determinants, for example, you can use technology to address physical environment factors such as air and water quality, right? Such as neighborhood safety and access to recreational spaces, all of which we know are very crucial for health and well-being. So I think having multidisciplinary teams that include social workers and community health workers with technology will be able to address these broader issues. And a lot of interventions, especially with social determinants, require that personal touch, understanding of the patient context, which I said technology cannot fully replace. So that's it. There are a few more, like, health literacy, like, data privacy concerns and security that will hinder adoption of these digital health tools. But I think addressing these challenges with a combination of technological enhancement and alternative strategies, like you asked, safety net providers and hospitals can better meet the needs of patients and improve overall healthcare outcomes.
Absolutely. And you touched upon like humanizing the technology, the health technology aspect, right? That is absolutely critical especially in primary care settings and with all of this sort of big tech. I see a lot of that. That's kind of where I come from. That's been my view into health care and health tech. There's always conversations that happen to like B to B to C. And I've been using this language of because we start with words and that's how we can start change, to talk more about B to B to H instead of business to consumer, because healthcare is not consumer care, it's health and it's for human. So B to B to H, B to business to human. And as a starting point, when we start thinking of, even some of these technology providers that are getting into the health tech space, and given their vast pockets and deep pockets, they have the ability to make change, but they also lack the insight on where healthcare is in the history, as you spoke. In the second aspect of what you talked of, so the social determinants of health, and Shahi, I'm coming to you with this question. Information as a social determinant of health, or access to information as a social determinant of health. Because if we're all moving towards digital health, and digital health is health in the future, but there is a vast population that cannot access it. Thoughts on information as a social determinant of health, and do you have any successful pilots? It's not all gloom and doom from your work at Tulsa Labs on adopting some of these, especially for safety net systems? Yeah,
I don't think we have any direct pilots that can speak to the effects of broadband access on healthcare outcomes, but I have seen folks like the Pew Center of Research, as well as, I am blanking on the name, but I've seen multiple research institutions, sort of the Commonwealth Fund as well. These are the two institutions that have extensive research on broadband access and how broadband access has a direct correlation to health outcomes and health access because it improves connectivity to loved ones, because it improves access and knowledge about how to take care of yourself, and because it improves healthcare navigation. And so we are starting to see more and more of that. I think one thing that we will see coming in the future really is, more efforts to bridge that gap. So unfortunately today, about 27% of rural Americans lack broadband access, and that statistic is only higher within tribal communities. And so we are starting to see more and more investments from public sector, namely the federal government and a few states step up. So I know quite in the last 2 years, the U.S. Department of Agriculture has come out with the Reconnect program that has committed $1.5 billion to broadband expansion in rural communities. And just this year alone, we also see states like the state of Virginia, as well as my home state here in Oklahoma, commit large amounts of ARPA funding for rural health broadband expansion. And here in the state of Oklahoma, this happened back in January, and they committed about another $370 million to broadband expansion in rural communities across the state. And so we're definitely starting to see not only the federal government, but state government start to put their money where their mouth is when it comes to investing in broadband expansion because of its implications on health outcomes and education outcomes and financial mobility outcomes.
Absolutely. And we're also seeing a lot of investments coming directly from the federal government as well, focused on women's health, because I think we're at a crisis moment. And as we talk of safety net hospitals in safety net primary care, adding that additional focus of women as some of the most underserved in our communities, it's also very heartening to see some of that additional focus in very specific focus coming from the federal government as well. But the barriers remain, and Irene spoke briefly about this. I want Shahi, you to take the first stab at this, but also Abner, I'd love for you to chime in. There are a lot of barriers to implementation. Irene spoke briefly about literacy and health literacy, but also digital health literacy in adoption of some of these into the primary care settings. And going back to what Abner was mentioning in terms of the Medicaid, adoption of these can become the first kind of roadblock, right, in entering the care ecosystem for the underserved. Thoughts on how some of these could be overcome, especially with the literacy side of things, or if you have additional thoughts on what those additional barriers are?
Yeah, I think you are absolutely right about the fact that patient adoption of these technologies may be some of the first, and if not one of the biggest barriers to adoption. I think what I implore providers and healthcare systems to think about is understanding the community in their backyard. A lot of telehealth is sort of telephone based, not smartphone based. And we're definitely seeing more adoption of telephone, text, and call based solutions as opposed to solutions that require someone to download an app or interact with a web page. And so understanding where your community is today, I'm seeing a lot of research come out of many parts of Southern California, where they have very large immigrant populations, and they're starting to see, the manifestation of those trends is that, the patients are much less comfortable and much less open to adopting these technologies when it is smartphone based. But if they are allowed through text modalities or call modalities, they're significantly more likely to adopt. And I would say, on the other hand, it's not just adoption from the patient side, but also from the workforce side, right? How are the providers? How willing are they to integrate it into their workflow, and how cumbersome is it to integrate it into their workflow, right? Right. In today's America, many providers spend up to 40% of their time on administrative work. Is this going to add to that administrative burden? And so making sure that when these technologies are developed, they integrate onto the systems that are currently being used is going to be key to overcoming barriers to adoption.
Yeah, and in the rooms that I am, where I get pitched a lot from digital health startups, the first question I ask is, and especially, these days it's about apps and natural language processing, so that, our text is converted, our speech is converted into text, and it can be incorporated into the doctor notes and things like that. And it's all starts with the premise, like you said, that it's on a smartphone. Or it starts with the premise that it's primarily English speaking. And that's not the case, especially in our safety net primary care practices. And there's a huge demographic that is completely underserved. And Abner, I know you've done a lot of work with the cultural focus of healthcare, and I'd like to have you comment on how can some of these, even advise or guidance to the startups, but also to the audience that's listening in, providers, what should they be asking, payers, health systems, what should they be asking as the table stakes when it comes to digital health technologies, so that it can serve the underserved communities?
Sure. A couple things. One, I think Sahi is absolutely right about the importance of that user interface and making it easy for everyone, but certainly underserved populations, to use technology. So I'm going to make a pitch here for the need to make it possible for text messaging to be used more commonly across healthcare, especially by Medicaid managed care plans. In today's America, the way that people communicate is not US mail. It's not even email. It's not even phone calls primarily. It is texting and native texting, not even downloading an app. Nobody wants to download an app. So at my company, we really have spent so much time understanding this for underserved populations, for different cultural communities across the country, and overwhelmingly people want to engage in native text messaging, just text. But the problem is there are old laws, and this goes, it's called the Telephone Consumer Protection Act. It's a federal law. It goes back to 1993, even before text messaging became the common way that we communicate. And it basically, I won't get into the details, but it makes it very difficult for Medicaid plans in particular to engage their members using texting. We work with Medicaid plans. As recent as yesterday, we were struggling with a large national Medicaid plan, trying to convince them to let us text their members. And they're saying, we want to do it, but our lawyers and the risk people are saying that law is preventing us from doing it. So I'm saying today in America, most Medicaid plans are unable or struggling to communicate with their members in the way the member prefers. So we got to fix that. That law needs to be fixed. We've got to pull policy into this year and not be living with policy that is from 1993, because technology has changed, people have changed, their expectations have changed. So we got to deal with that. I think and you raised a good point about this whole idea of personalization. What primary care providers and basically the whole healthcare system, I believe, should be moving towards is truly personalizing the way that we treat people. We've got to get away from this one size fits all. That is the way healthcare has worked more often than not. There are, legal reasons it was safer to send one message than it was easier, and you didn't have the technology, 30 years ago to do it. Now people are accustomed, healthcare consumers, whether they're a patient or a health plan member, they're accustomed to being treated like who they are matters. Netflix, I'm sure some of you have Netflix. If you can have 6 people in the same house, and they might charge you, but every person gets a different set of recommendations. If you go on Amazon, I challenge you to buy a pair of shoes on Amazon, one pair of shoes, and before you know it, they will start to personalize the engagement and the recommendations. They'll treat you like who you are matters. They won't say just because you look the same, or you might have the same color skin, or you might live in the same state, that you're the same, because we're not. And so what we've said is, if we can use the technology to personalize the experience, bring healthcare into 2024, and meet the expectations that healthcare consumers have, we can build trust. We found that when you treat people like who they are matters, you build trust. That trust allows you to navigate people into healthcare at the right time, the right place. So I'm bullish on the technology and the ability to use data and technology to personalize the relationship. But our healthcare system we're still way behind the rest of our culture in the way that we treat that healthcare. And I'm going to use the word consumer, but it could be a patient, it could be a member, anybody who wants healthcare. We've got to figure out a way to treat them like who they are matters. Because when we do that, we build trust, and it makes it much easier for us to then deal with the other issues around health literacy and other things.
Yeah, and Abner, you've actually hit on one of the important points about barriers to adoption, which is the trust, the transparency about how the patient data is collected, how it's used, how it's protected. And so clear communication about these, the data can help to build trust, right, in these digital health tools. So I totally agree.
Yeah, and I think you have such an important point there, Abner and Irene, coming from the consumer world into a consumer patient world. That's how I view it. It's a huge difference. You get that personalization on Amazon, Abner, because they collect copious amounts of data on you, which is fantastic because it's very targeted to you. But at the same time, how can we bring that consumer patient experience to our patients, and mostly to the most underserved? And I'll give you this statistic. It's actually not even a statistic. It's a fact, and you alluded to it. You are more 300% more likely to open a text message versus an email. And you are, I think it was 5,000 was the percentage, and I'll quote the study. I'll bring it back into the chat here in a little bit, to open a text message versus snail mail. So what you're alluding to is that, we as humans have evolved into this world where we are all digital first, and it's very natural, but we are not doing that in our healthcare ecosystem.
Absolutely, and it's a challenge that it requires federal legislation. And I know that's a heavy lift. I'm not being critical, but our representative in Washington struggled to get anything passed. But we've got to push up, and really talk about this as a problem that needs to be solved, because it's not solved. It's actually, in my view, worse than it's ever been, because the need to engage is higher than it's ever been. The expectations that patients have about how they're going to be treated, if we don't match that expectation, they're not going to engage with us. And that's what we found, that they just won't engage. And so we have two choices. We can say to patients and members and healthcare consumers, you need to change and think the old way in order to get healthcare, or healthcare can change and get more modern so that we can engage people in the way they want. And obviously, people aren't going to go backward. And so we have got to pull healthcare into 2024 and start treating people, meeting their expectations about how they expect to be treated.
Absolutely. And my next question is just taking that idea that you need to meet the people where they are in the community, and also with the technology adoption. Eileen, you are no stranger to digital health or health technologies. You've been working on it long before it became this cool. We have published tremendous amount of valuable data and research and publications, and you've also been very vocal about the disparities that the newer technologies, such as artificial intelligence and machine learning, could introduce if not thoughtfully implemented. For example, like diversity in clinical trials and things like that. Can you educate us a little bit more? What should be those key considerations to ensure that AI and ML technology adhere to health equity and ethical principles, but also principles of social justice as you think of development and deployment? Irene.
Yeah, thank you. And that's a great question. I mean, I would off the top talk about a huge key consideration is, as we all know, preventing bias, right? And this should be a real huge priority for every stakeholder that's involved in the AI machine learning technology development pipeline. So I'm not only talking about just the developer of the AI clinical tools, right? But every single person, the scientists, the primary care provider, other healthcare providers that are generating data, right? Making sure that all along the continuum of generating that evidence that goes into our AI and machine learning tools have been checked for bias. And so it should not definitely be an afterthought. So the possibility of bias really needs to be actively considered and tested, right, throughout the phase. And so making sure that there's bias mitigation means data diversity, ensuring that the data is diverse, representative of various populations, making sure that we also have algorithm audits. That's very, very important. Regularly auditing for bias and implementing mechanisms, right? Because we know our AI tools, it's still in development, correcting for any identified bias. The other thing is transparency and explainability, using explainable AI techniques and making the decision-making process of AI systems transparent, clearly communicating the potential risk and all that. But I think a huge one is inclusivity in design, right? Designing the AI systems to make sure that they're accessible and beneficial for all populations, including socially disadvantaged, including disenfranchised, every community, right? And so assuring that there's equitable resources and technology to be used. But I think when we talk about ethical dimensions of social justice, it goes beyond just the development, but also looking at bias and discrimination, looking at empathy, looking at fairness, human oversight in the process. It's not just AI, it's AI and humans in the loop. And so having sort of that moral agency. One thing is having ethical review boards, right, during the development and making sure that there's an interdisciplinary collaborations with teams in this space. So there's thank you for this question, but we need to really do a better, robust job with all relevant stakeholders in the AI and machine learning pipeline.
And that resonates so much with everything we've heard all day today in all the other panels as well, Irene, which is access to power, having a seat at the table. Sahi, what do you perceive? How can these technology tools, if implemented right, be able to give that access to power in the seat at the table for the underserved communities?
Yeah, I think and I know to address that, I'm going to double click on a few points that Irene just made. Considering that a lot of our audience are providers, practically what that means and how to make sure that your data is not biased and that you are having the adequate representation to treat the patient adequately, is asking, where did that data come from? It is as simple as that. What communities does it come from? What zip codes? What ages? Is it just folks that can afford to have private health care? Does it include Medicare and Medicaid population? Quite simply asking, where is the data coming from whenever implementing any type of AI solution is, I think, the easiest step to ensuring that there's adequate representation. I think another way that they can ensure that they are meeting these representation standards is sort of unique partnerships with entities, nonprofits, government agencies. We're finding more and more organizations that are becoming dedicated to representative health data. And so, I'm thinking immediately of NIH's All of Us program, where they're getting a representative health data set together, thinking about the Agency for Healthcare Research and Quality, the National Institute of Minority Health and Health Disparities. They all are working on this and are eager to partner with upcoming startups, established organizations and healthcare systems that have these big questions around, well, is it representative enough? Is it doing what it says it does? What extrapolations is it making? And what I mean by that last point is, I remember when I first sort of started to did a case study on health AI and health AI implementation back in 2018. And I was looking at a health system that was using an AI solution to triage patients, but the data that they were using was claims data. And because of that, the algorithm was unjustly underestimating the amount of care needed for low-income and minority patients, because low-income and minority patients are not well represented in claims data. And so thinking about where the data comes from, who can you partner with to make sure that you have the most representative and up-to-date information, and then thinking about what extrapolations is that algorithm making, and does that actually make sense? Because it really doesn't make sense to use claims data to evaluate a person's level of need, right? So I think those were the big pieces that I would implore people to think about when adopting new AI solutions in their clinic.
Yeah, and representation matters. And, it is important to ask, where does this data set come from? What is included in these data sets? And as we heard also in the mornings, when you get data, don't bundle it, right? And that was one of the panelists in the morning panel speaking about, if you have 18 different identity groups that are represented in your area, keep them as 18 different identity groups. And so not trying to bundle and assume, because when you make the assumption and input that data in that way, the technology is going to make further assumptions. And I think at the precipice of generative AI, where input data is actually creating new meaning and new data, it's very, very important to focus and ask those questions about, where is this data coming from? And representation matters, and that's what we've heard, which brings us to this very interesting dynamic we're seeing happening in our country. There has been much discourse and debate on the Supreme Court's ruling ending affirmative action and its significant impact on medical education and diversity in medicine, potentially undermining the substantial progress made over decades to creating a diverse healthcare workforce and reducing those health disparities. Abner, through your roles at California Black Health Network and other positions, have you seen any immediate impacts of the SCOTUS ruling on affirmative action in the healthcare sector?
I think I was beginning to see, and this is, I don't have data, it's more anecdotal at this point, but I was beginning to see a change happening even before the Supreme Court ruling, because we had in our country this huge moment that it was a result of the disparate impact of COVID that came at the same time as the murder of George Floyd. We had this moment in America where I think we sort of looked at ourselves in the mirror and said, we don't like what we see and we need to make changes. And so there was a huge push around social justice and racial justice and health equity. And every company did stuff, and health systems took steps. It was all important. This is good stuff. It should have happened a long time ago, but it started to happen. And that's a good thing. But I started to see as COVID was coming to an end, and we got some distance from the George Floyd sort of that moment of reflection. There has started to be some backsliding, less focus. You started to see companies say, well, there was a priority last year, but it's not going to be this year. And I was already starting to see some of that. And then the Supreme Court case came along. So a couple things, and we can certainly talk about this. What I'm seeing is that there is a difference, a perceived difference between health equity and DEI, diversity, equity, and inclusion more generally. I think there's kind of a divergence happening. And on the health equity side, there is more willingness and interest in continuing to do the work. I think there's an easier to demonstrate ROI, return on investment, for health equity work. Thanks to NCQA and some other folks, we're starting to collect data now in the way that we didn't used to, and it's stratified by race and ethnicity and language and sexual orientation, all those other demographic categories. And so when you see the disparities, it's hard to say we ought not work on that. It's hard to find in America, and there are people who say, I'm happy about people not getting adequate health care. When they see the disparities, you have data, it makes the case for doing something a little easier. Not easy, but easier. And I think so I continue to see that work continuing. And because of the data, we can make a case for the need to take action. And actually, we can make a case for the actions that we take having an impact. When you can measure ROI, if you can close the disparity, you say that money's well spent, that effort's well spent, those resources were well spent. So it's easier. DEI more generally, I think we're going to have a tougher time because it's harder to make the business case for it. I think it's the right thing to do. It's the morally right thing to do, but it's harder to make the business case. And I think what I'm seeing is people moving away from race-based kinds of considerations and moving toward income-based, because that doesn't run afoul of the Supreme Court case. So you're starting to see universities and other folks saying, well, we're gonna have an affirmative action program, but it's not going to be a program that's designed around race. It's going to be a program that's designed around low income. And so low income kids, for example, we're going to go out and try to help those kids and people who've overcome economic challenges. And that includes everyone, not just folks of color, but everyone. So I think that's what I'm seeing. I think we're going to see more of that on the DEI side going forward. But that's just what I'm seeing. I'd love to hear other thoughts.
Yeah. Irene, any thoughts on that that you wanted to share?
I mean, I was going to, I totally agree with what Abner said. I think that there is pressure, employers are facing pressure from stakeholders in litigation, those that are seeking to reaffirm their existing DEI commitments are sort of trying to struggle where they need how to balance their commitments. I think that, so there's actually greater scrutiny, right, of the existing DEI commitments. And so they're looking to figure out, whether their programs are permissible and really evaluate whether they're really discriminatory, practices. When, in terms of, we know that this is all a social mission, somehow the definition has reversed or changed, and people are just feel like they're stepping on eggshells, or and trying to figure out what to do. So I think it's more, really greater scrutiny of these DEI initiatives, especially by those who believe that those initiatives are leading to differential and potentially discriminatory treatment. So most people, everyone is looking at their programs and initiatives and everywhere. And I agree with Abner. I mean, instead of racial and ethnic, being a part of the social justice, they're looking at socioeconomic status just to be safe.
So in terms of the pipeline, right? So we have now, a change in how we could access for racially diverse and socially diverse could access education. And we are looking at universities doing, socioeconomic changes, focus on socioeconomic disparities versus just, identity or race. But that was the source of the pipeline. How do you think that the healthcare industry itself, when it comes to actually its workforce, could do some of the hiring and training without relying on affirmative action, similar to how universities are now focusing on socioeconomic? Any thoughts on how that could look like and not relying on affirmative action for ensuring that the workforce is diverse?
Well, I would say that within the health workforce, right, we have an obligation to take care of diverse patients. And so it means that if we're doing, health workforce equity, it translates to, providing culturally competent care, culturally sensitive care with compassion and with the competence to improve patient outcomes. And so in order to do that, right, you need to have that skills and training. It has nothing to do with, discriminatory practices we are in an era of precision medicine and personalized care and patient-centered care. And so we don't have, any excuse not to provide that care for patients to improve their care, for that precision care, that culturally competent, appropriate, relevant care for patients. Otherwise, it's not justice. It's not fair or equity. It's not patient-centered. And so I think we, you can couch it that way. If someone sees us as health equity, well, it's more, if this is the era of personalized medicine and patient-centered or precision medicine, that's the way we need to practice, or that's what we need to do.
Very, very, very important point in terms of the focus in healthcare is always about serving the patient. And if the patient is diverse, and if the communities that we are offering care to are diverse, then that's the need that we are trying to solve versus any other consideration. Which brings me to a point that Abner made, and Sahi, I want your reflections here, where he specifically delineated, the DEI efforts, the equity efforts, versus, say, the group that controls financial decisions, financial outcomes, and investments. They're two different groups in most companies, even in health systems. It feels like the DEI effort, here you can do the social justice parts, but then somehow the DEI efforts, it seems decoupled from your financial P&L in actually being profitable, which should not be the case because you're serving the overall communities. And so there should be a case made for prioritizing investments into offering diverse supports, being able to support safety net practices. What are your thoughts? Because I know that you're building this ecosystem and investment in startup ecosystem around this. Thoughts on that?
Yeah, I think though there isn't much data out there, there is data. I know at the end of last year, Deloitte came out with a fantastic report where they sort of took a look at different companies, both, larger conglomerates and smaller startup-based companies, and looked at their financial success as it related to diversity, equity, and inclusion metrics. And what you find is not only does it make for more resilient business cases and approaches, because the more representation you have within your team, the more populations you're able to serve. But also it found more protection against lawsuit and liability, more protection against unintended consequences that may be costly down the line. And so I definitely think there is, and though there is still, that is an area of research that needs to be explored further, there is some data to suggest that those two should be more closely related. And I think the closer we are to start understanding how this not only, feels good or is good for the common person, but it also is good for the bottom line of the business, the better off we will be. And I think there are strong arguments for that.
Absolutely, absolutely. So we come back to this point that unless there is a diverse workforce that intimately understands the challenges of the underrepresented communities, we perpetuate these cycles of exacerbating, the existing inequities and disparities. But it's also fundamentally, poor business logic and poor business sense. And to have diverse workforces, we need to have diverse communities that have the opportunity to be educated and equipped to participate in those health innovations and ecosystems. Right. So are we doing healthcare fundamentally wrong? Shouldn't healthcare really be focused on most effective care versus being profitable? And if we took this approach to healthcare, where maybe it's just let's break even, and again, not being socialist, but doesn't that make more fundamental sense for caregiving? And we heard a lot of this in the earlier conversations today. Would we be serving all communities better if we thought of healthcare in a fundamentally different way? And I want, Abner, you to respond, but I would love for all of you to take a note on this particular one, and then I think we'll move on to the audience questions.
Sure. So I made a pitch for texting because I think it frustrates me to no end that we can't use a basic, sort of capability like that to engage low income and underserved and Medicaid populations. Here's my other pitch, my last pitch for the day, which is I'm excited about what is happening in the social care space, and specifically tech-enabled, social care. Full disclosure, the company Ground Game Health that I work for does this, but I'm super excited about it. Basically, we have had in our country this problem that clinical care was separated from social care. It's always been the case forever. It doesn't make any sense because what we all know is that the social determinants of health, or health-related social needs, are much more important to a person's health, 70, 80% than what actually happens in the clinic. Yet we completely separate them, clinical care over here and social care over here, and we spend a whole lot more on clinical care than we do on social care. Well, we won't give a person any money to get a decent meal, a healthy food, but we'll spend tons of money on diabetes and it happens time and time again. So the good news here, though, is that there are a number of companies that are building solutions that are trying to bridge that gap. The government, the federal government in particular, has gotten involved on the Medicare side with what they call the supplemental benefits program. So for seniors who are on Medicare Advantage, you can use some of that premium dollar, and Sahi talked about this to help pay the electric bill, or to make a modification in the house so that senior doesn't fall, or to help them with transportation so they can get to an appointment. Someone just put in food as medicine. You can actually spend money to help that senior eat and not wait till they have a crisis and end up in the hospital because they didn't get adequate food. California has a new initiative called CalAIM, which is they're transforming the Medicaid program in California called Medi-Cal, where they are really leaning on community-based groups to. They're basically saying is, we don't want to medicalize social care. That doesn't make sense. That's not the solution to meeting social needs of people. Why don't we work with community-based groups? They're in the community. It actually solves some of the employment needs and training needs. And because these people are in the community, they're food banks, food pantries, and transportation agencies and housing agencies. They are trusted in the community, but they up until now they haven't been able to get paid for doing the work that they are so good at doing. And now there's this opportunity to connect the managed care plans. I'm talking Medicaid in particular here. The managed care plans who are getting a lot of money from the government. And they are willing to spend some of that money to meet the social needs of their members, but they have been unable to sort of connect. We're connecting them. That's what we do at my company, Ground Game Health, but there are other companies that do it as well. I'm not pitching our company. What I'm saying is this is an important solution moving forward. We have got to figure out a way to connect to meet the social needs of people. The best way to do that is to use community-based groups. We need to get rid of the silo between clinical and medical, have those folks work together. That's a bright spot, I think, and it's an opportunity for us going forward.
Awesome. Irene?
Well, I was going to say, so I worked for 8 years in the public health department. It was Health and Human Services, and we developed collaborations with hospitals. I think we sometimes forget that the public health department really wants collaboration and promote public health and promote social services. So that was sort of what I was going to add to what Abner so eloquently described.
Absolutely. Thank you, Irene. And Sahi?
You're on mute.
Thank you for that. Coming back to the original question about, are we fundamentally doing healthcare wrong? I don't think there's any one right or wrong way, but we need to work with where we are today and leverage the resources and these movements and the changes that we're seeing in policy and that we're seeing in patient attitudes, as well as in startup and technology and innovation approaches, and make sure that we are, bridging those connections, bridging those gaps to sort of push us to where we want to be with the parameters that we are currently given.
Yeah, and that, I was going to go tread, but there is such also a disproportionate amount of investment of funding into prevention, into, primary care. A lot of funding goes into research, into technologies. And I think that's also where, the reason why we see this sort of healthcare fragmented healthcare system, because of, disparate funding. And so if we also look at funding prevention and what are all, preventive social services in the same way that, or balance it with the research, which we know it's so much needed, or the technology, we will be far ahead.
Absolutely. Thank you, Irene, Abner, and Sahi, for this enriching conversation. We can definitely see the rapid changes in digital technology is going to make a huge impact. With that, let's take some questions from the audience. I'm going to just quickly look into the chat here. Let's see. Okay, let's see. First question, have there been studies done in different geographic locations that show a significant decrease in healthcare? For example, I'm from the Midwest and I moved to a southern state. I have noticed a decline in care, but not an increase in cost. Interesting. So I'm paraphrasing here, but it basically seems like they're saying the quality of care is getting worse, but not the cost. And the question here is there a study that you guys are aware of that has looked at the, sort of location-based, demographic-based, community-based to show the quality of care decreasing? Anything, Sahi, in your world around the?
Yeah, so I'm not sure about any studies that indicate to decreasing health outcomes, but I definitely know of studies that indicate a gap between different demographics in health outcomes. And so to give you guys an example, just here in the city of Tulsa, in North Tulsa, which is predominantly Black, and South Tulsa, which is predominantly white, there is currently an 11-year life expectancy gap between those two zip codes. And it is literally a 20-minute span, a drive between the two. But you definitely see in communities and populations where, again, access to things that contribute to social determinants of health, access to childcare, access to sustainable living conditions, access to food, all have meaningful impact on how care and, on life expectancy and quality of life. And I think you see this repeated in many geographies, and even just beyond, this city, the life expectancy between an urban and a rural individual is also somewhere in the 8 to 9 years life expectancy gap. And so you're definitely, and you can, throw some assumptions around why that is. And it largely revolves around, again, access to healthcare, access to broadband, access to healthy food, and access to the information that allows you to take ownership of your health. And so I think that there's definitely a lot of data around that. But declining health, I'm not too sure about.
Yeah. Irene or Abner, do you have any other further inputs? Because there's some really interesting questions coming up that I also want to field to you guys.
Nothing to add from me.
No, not me either. I was just going to say, I think it'll be interesting to look at comparisons of quality across different geographic regions and cost. But this is where I guess we're all really moving towards sort of value-based care. And when we talk about quality, I mean, it's really a lot of things, including, the safety of the intervention, the timeliness, that's sort of the effectiveness, whether it's equitable and whether it's patient-centered. And so there might be different influencing factors that will drive quality and outcomes in the various regions.
And that's a great segue to the next question, Irene, which is, would you address the question of value-based care, and who decides what is valued and by whom? Is it a term often associated with a company, hospital, insurance, saving money, lowering cost, getting good metrics, but not necessarily with what matters to the patients or clinicians? Who cares for us/them? So I think it's getting to what is truly value-based care and how are we operationalizing? Irene, do you want to take that?
Yeah, I can start. I mean, I think when we talk about value-based, it was a shift from providing a lot of, quantity as in moving towards quality, moving towards incentivizing physicians and healthcare providers to focus on the quality of care they give. And the quality of care meaning that it's safe for the patient, it's patient-centered, it's timely. And so it's not, you're basically providing care to the right patient at the right time with relevant clinical evidence. So that's actually value-based. So it's really more than, and it definitely includes, the patient's perspective and the patient's quality of life, right? In addition. So the compensation that's provided to pay for the services is based on the patient's health outcomes. And your health outcomes, right? I mean, it's a patient who will tell you that for them to improve or to feel better, it really definitely includes their perspective as well. So that's built in when we talk about the true value-based care.
Yeah, it is very interesting. It's definitely, for me, the way I kind of try to rationalize is it's, value always means you're getting more for less. But that doesn't, how do you create that in a healthcare ecosystem in terms of reimbursements and focusing on outcomes versus just fee for service? I think that's a whole panel in itself, I would say. Not for today, probably. There's two additional policy related questions, which I think it's super critical for this day and time that we're in, health tech. Are there other examples like the Telecoms Act where policymakers could and should address to actually drive health tech transformation? Like, is there anything specific? There are a few on the AI that I could talk to, but Abner, do you want to address that?
Well, in addition to the Telephone Consumer Protection Act, which we need to change and update, I believe that we also need a significant update of HIPAA. I think that we have made HIPAA, it's almost a fetish. I mean, it's unbelievable. You can go anywhere in America. And first of all, every problem is HIPAA, and people don't fully understand it. And if you fully understand it, you realize that it's outdated. I mean, we're still living with a data protection legislation and policy that bears no connection really to what we actually have to deal with today in terms of data. So I think we need a significant update of HIPAA. I would definitely put that there. And I know people get nervous when you talk about personal health information or health information. Look, we're never going to get where we want to go if we don't figure out how to manage data in a way that is rational and that takes into account the new technologies that we have, and that take into account what people want for themselves, and maybe gives people more authority over their own personal health information. Because during COVID, people, they did a lot of studies, and particularly younger people, they're much more comfortable sharing than older populations, for example. So we've just got to update and I think lean into giving people more control of their own data and how it's used.
Absolutely. Shahi, any additional add-ons to that one?
Yeah, I would say at the state level, really looking at policy around reimbursement reciprocity for digital and remote care services. Like it's right now, as it stands today, in many states, it is very difficult to reimburse for telecare, virtual care, and that creates a significant barrier to adoption and implementation. And so, really having those conversations with your state leaders about what it may look like to have policy around having reciprocal reimbursement for virtual and at-home care is going to be important to sort of bridging this gap, especially as we stand in the face of a widening provider shortage that is only expected to increase in the next few years. So thinking about how we augment our current provider staff using technology, that's going to be a big part of that. So that's definitely one piece of policy that I hope to see change in the coming years.
Awesome. We're almost at time. I just want to say thank you. And if we didn't get to your question, then we're just out of time now. But all of our panelists, please reach out and ask. They're always happy to share. Abner, Irene, Sahi, thank you so much for this amazing conversation. Yes, I mean, we're at the precipice, and hopefully in the future, when we have this panel, we're not talking of digital health or other health, like it's synonymous and it's the same. And we've solved, some of the most fundamental equity and access issues. And that's my hope. And with that, I will pass the mic back to Karen.
And I'm going to turn it over to April Joy for closing remarks.
Well, thank you so much, Karen, to our panelists and discussant. I mean, just really, we were commenting to each other internally that it really just felt like flies on the wall with this fireside chat, as if you all knew each other for ages. So just really appreciate your discussion and those who contributed to the chat and the questions that were listed. So that really wraps up today's symposium, but I just want you to stay tuned for just a few more announcements. So first, we definitely want to hear from you about your experience with today's symposium. And so we ask that you follow the link in the chat to complete the brief survey. And if you'd like to claim continuing education credits, please follow the survey link. And at the end of the survey, you'll find instructions on how to claim credits. I would like to also thank our exceptional speakers today, our Weitzman Symposium planning team. And again, a huge thank you to all of you joining us today. We hope you enjoy the program and really look forward to seeing you all at next year's symposium. Thank you.